Hello everyone, nice to meet you again. This is Miley from the Respiratory Department. In this class, we will learn a new disease, bronchial asthma. In Chinese, it is called 支气管哮喘. In this class, we will learn about the introduction, clinical manifestation, auxiliary examinations, diagnosis and treatment of the asthma. And at last, we will have a case discussion. Firstly, let's look at the definition together. The asthma is a heterogeneous disease, usually characterized by chronic airway inflammation. It is defined by the history of the respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. It's the definition from the guideline of the GINA 2019. The definition of asthma is complicated, but we can try to pick out some keywords to help our understanding. The first keyword is the heterogeneous. It's about the etiology of the asthma. The most important cause of the asthma is allergy, including the pollen, dust, microorganisms, and so on, and others include the asthma gene, heredity, and so on. Once the causes of the asthma exist for a long time, it will induce two specific pathological changes. One is the chronic airway inflammation. Please notice here, the eosinophils plays the most important roles in the chronic airway inflammation, and other cells can also take part in the chronic airway inflammation, including the mast cells, neutrophils, and so on. In recent years, the investigation of the kind of the predominant inflammatory cells is one of the most important fields of the research for the asthma, because it's related to the treatment effect and the prognosis of the asthma patient. And next, the cytokines produced by these chronic inflammatory cells will finally induce the constriction of the small muscle cells in the small bronchi, which will result in airway hyperresponsiveness, and is also called airflow limitation. This airflow limitation is variable, and the patient usually present extension of the expiratory phase. That means this patient will feel expiratory dyspnea. Based on these two specific pathological changes, the patient will present some special respiratory symptoms, including the wheeze, shortness of breath, chest tightness, and cough. The wheeze and shortness of breath are also called dyspnea in all. There are two groups of the etiology of the asthma. One is the environmental factor. Another one is the host factor. Let's look at the first one firstly. This picture shows the most common environmental factors, such as flowers. The asthma patient usually get acute episodes during the spring. Animal hairs. Parasites such as mites and so on. Some toxic particles including the dust, smoke, and pollution from the factories. Some foods can also take part in the acute episodes of the asthma, and some medicines such as aspirin. And sometimes the weather, exercise, and extreme emotion can also induce the acute episodes of the asthma. That's the environmental factors. And about the host factors, the most important is the gene. For now, there are lots of new investigation and research for the asthma gene. If you are interested in these studies, you can search online and download for further learning. The asthma gene usually present a familial aggregation. That means if the mother or father got asthma, and the children are likely to get any kinds of the allergic disease. And others, including the obesity, gender, and so on, is about the host factors of the asthma. About the pathogenesis of the asthma, there are some theories. The most popular one is the immune inflammation theory. Let's look at this picture. Once the allergen is inhaled into the respiratory tract of the patient, there are some specific cells will be activated step by step, including the macrophage, epithelium, dendritic cell, mast cell, B cell, eosinophils, neutrophils, and so on. These cells can produce some special cytokines to induce some special changes, such as the mast cells and macrophage cells can induce the production of the histamine and leukotrienes, which will induce the construction of the airway smooth muscle cells. And this process is called airway hyperresponsiveness and remodeling. And others, such as the B cells and mast cells, can finally produce IgG and other interleukins, which will cause the chronic eosinophilic inflammation and finally results in the damage of the pulmonary function. The chronic eosinophilic inflammation is sensitive to the treatment of glucocorticoids. And the activation of other T cells, such as Th1 and other T cells, will finally activate the neutrophils, which will result in a chronic neutrophilic inflammation. This specific neutrophilic inflammation has no response to the treatment of glucocorticoids. From the pictures in the last page, we can know that once the allergen enters the body of the patient, it will activate the inflammatory cells, which will result in different chronic inflammation. And the allergen can also stimulate the structure cells, such as the epithelial cells and so on. And this reaction to the allergen will finally cause the effects, including the bronchial spasm, plasma exudation, mucus secretion, airway hyperresponsiveness, and structure changes. Let's look at more details about the airway hyperresponsiveness. Airway hyperresponsiveness is caused by the stimulators, including the allergen and other agents, drugs, and so on. It usually occurs in asthma patients with respiratory symptoms. This specific reaction can also exist in the patients with chronic obstructive pulmonary disease, upper respiratory tract infection, smoking, and so on. Once in my clinical works, I usually found that most patients will complain of chronic cough after acute respiratory tract infection. It will last for half a month to 2 months. In this condition, we will consider the airway hyperresponsiveness caused by the acute respiratory tract infection. And for these patients, we can supply some anti-allergic drugs or sometimes the glucocorticoids for this chronic cough. And this reaction is familiar clustering. The patient with airway hyperresponsiveness has well response to inhaled glucocorticoids. About the structure change. Structure change usually occurred in the asthma patient without well controlled for a long time. It's caused by the persistent inflammation in small airway. So, it's important for the asthma patient to control their disease following the gradual therapy. Once the structural change occurs, it will mean the bad response to the inhaled glucocorticoids. In this condition, the asthma patient will present the symptoms and signs with the invariable expiratory airflow limitation. That is the asthma COPD syndrome. For short, is ACO, echo. It's a very special subtype in the COPD. According to the timing of the asthma onset, after inspiration of the allergen, the asthma patients can be divided into 3 subtypes. The first one is the immediate asthmatic reaction. The asthma onset usually occurs a quarter or half an hour after inhalation of the allergen and lasts for a short time. And the late asthma reaction usually shows the asthma onset occurs after 6 hours and lasts for several days. And the bipolar asthma reaction is between these two subtypes of the asthma. There are other theories, such as the neurograduatory mechanism, infection, such as the fungus, including the aspergillus, drugs such as aspirin, gastroesophageal reflux. If you are interested in these theories, you can find other information about these theories for further learning. This page shows the epidemiology of the asthma. Asthma is one of the most popular diseases, and nearly 40% patients are with family history. Let's look at these two pictures. The first picture shows the proportion of the population with asthma. We can find that the proportion of the population with asthma is higher in the North America, the South America, and Australia, but lower in the countries in Asia. But in another picture about the case fatality rate, we can find that the case fatality rate is much higher in the countries in Asia. And why it's different in these two pictures? I think maybe it's because of the neglection of the early diagnosis and regular treatment for the asthma in these Asia countries. This page shows the GINA guideline for the asthma. If you are interested in this guideline, you can download the files from the net. It's very important for our clinical work. It's updated every year, and here shows some important contents during these years. In recent years, the asthma COPD syndrome is the most important content of the GINA guideline. Now, let's move to the clinical manifestations. Firstly, let's move to the symptoms. The symptoms of the asthma patient is different in the chronic stable stage and acute onset stage. In chronic stable stage, some patients may be without any symptoms, and other patients may be with a slight respiratory symptoms. But if the patient in the acute onset stage, the symptoms will be specific. The first symptom is wheeze. It presents that the patient feels dyspnea, hard to breathe, and they will do forced breathing with fast and deep breaths. That is the wheeze. The second one is the shortness of the breath. It's a sensation of the dyspnea. The patient feels lack of the air, and usually with abnormal rhythm and depth of the breathing. The third one is the chest tightness. The patients will feel something pressing their thorax and disturb the breathing movement. The fourth specific symptom is the chronic cough. The chronic cough will exist with or without stimulator, and in many times they will occur after an acute respiratory infection. All of the four symptoms have the same characteristics. The first one is about the trigger. These four symptoms can be triggered or become worse after patients contact to the specific trigger or stimulator. And there is also a special day-night rhythm. The patients will feel the symptoms becoming worse in the evening. And furthermore, we also need to focus on the history of the patient. The patients with asthma usually have other allergic histories, including the allergic rhinitis, allergic dermatitis, and so on. And about the family histories, the asthma usually occurs in their immediate family. Okay, let's look at more details about the characteristics of the symptoms. Firstly, the patients with asthma usually got more than one types of the respiratory symptoms. If the patient got the chest tightness predominantly, it will show the chest tightness variant asthma, and some other peoples usually got just chronic cough, and that is the cough variant asthma. The symptoms of the asthma usually occurs virally over time and vary in intensity. That means the day-night rhythm and the season rhythm. The symptoms of the asthma are often worse at night or on waking. And the symptoms are often triggered by the exercise, allergens, cold airs, and so on. And finally, the symptoms of the asthma often appeared or worsen with viral infection. And finally, the symptoms can be alleviated itself or after using of the bronchodilators. And those are the characteristics of the symptoms. Let's move to the signs. In this table, we can find that the asthma patient in the stable stage, that means the mild intermittent stage, we can find that there is no positive signs in the physical examination for most cases. And if the patient are in the exacerbation stage, that means the acute on-site stage, we will find some specific positive signs during the physical examination. In the vital signs, we can find the increased respiratory rate, and during the physical examination of the lungs, we can find the barrel chest intercostal space increased during the inspiration. And in the palpation of the lungs, we can find the decreasing of the parameters, and the thoracic expansion decreased too. During the percussion, we can find the percussion notes change to the hyperresonance, and in the auscultation, we can find the decreased breath sound. All of these positive signs above are caused by the emphysema in the acute onset stage of the asthma. And in the auscultation, we usually can hear the wheeze in both lungs caused by the bronchospasm. And we can also find the prolonged respiration caused by the obstruction of the small airway. If the patient with severe exacerbation, we can find some other special positive signs according to this severe condition. For example, we can find the vital signs become worse, and during the physical examination of the lungs, we can find the paradoxical thoracic abdominal movement, and the percussion will become darkness. And during the auscultation, we will find the little or without wheeze because of the disappearance of the breath sound caused by the severe obstruction of the small airway. And extrapulmonary signs include confused or in coma, and paradoxical pulse shows the severe increasing of the intrathoracic negative pressure. And that's the signs in the patient with asthma. Now let's move to the auxiliary examinations. The most important part is the radiologic findings and the spirometry findings, and others including the laboratory findings. Firstly, let's look at the radiologic findings. This picture shows the X-ray image of an asthma patient. What can we find from this picture? Yes, I think most of you maybe think that it's nearly normal, right? But if you look at it more carefully, maybe we can find some abnormal signs in specifically. The first abnormal signs is about the level of the diaphragm. The level of the diaphragm is decreased compared to the normal people, and the density of both lungs also decreased too. This picture shows the suspicion of the emphysema, but it's no specific finding in the radi examinations for the asthma patient. And the values of the radiologic examination is for the differential diagnosis. So, for the asthma patient, we need radiologic examinations, X-ray or CT scan. It's not for the diagnosis of the asthma, but for the differential diagnosis. And next one is the spirometry findings. It's the most important examination for the asthma patient about the diagnostic criteria of the asthma. The first one is to measure the excessive variability in lung function. There are 4 examinations for this purpose, including the bronchodilator reversibility test, bronchial challenge test, exercise challenge test, and variability in twice daily PEF over 2 weeks. Let's look at them one by one. Firstly, let's look at the bronchodilator reversibility test. At the beginning of this examination, we ask the patients to do a single spirometer to measure their FEV1. And next, the patients will inhale some short-acting bronchodilators, such as sabratoma. And next, 10 to 15 minutes later, we will measure their FEV1 again and compare the results of these two examinations before and after using of the bronchodilators. The positive results shows the increase in FEV1 of more than 12% or 200 milliliter from the baseline. That means the data before using of the bronchodilator. That shows the positive results in adults. And the children just required the increasing in FEV1 of more than 12 predicted. The positive results shows the document active variability in lung function. The second one is the bronchial challenge test. Firstly, we also need to measure the baseline of the FEV1 before using any types of the drugs. And next, we ask the patient to inhale some stimulant drugs such as histamine and so on. And 5 minutes later, we need to measure the FEV1 again to analyze the differences between these two examinations. The normal regions of the bronchial challenge test is different, associated to the different drugs. In Chinese, we usually use the histamine for this bronchial challenge test, and the positive results is about the falling in the FEV1 from the baseline of more than 20% after histamine. Here, please notice that if the patient with a decreasing of the baseline of the FEV1, we cannot do this challenge test again, or else the patient will got a severe decreasing of the FEV1 and with a severe hypoxia, and finally this patient will be in danger. So please remember here, we just do this bronchial challenge test in the patients with normal FEV1 or with just slight decrease of the FEV1. And the third examination is the exercise challenge test. We should measure the FEV1 of the patient before and after an activity, including the pedal test or bicycle test. And the positive results is falling in the FEV1 of more than 10% or more than 200 milliliter from the baseline in adults. And in children, falling in the FEV1 of more than 12% in predicted data, or PEF more than 50%. And that's the exercise challenge test. The same to the bronchial challenge test. We cannot do this exercise challenge test in the patients with severe decreasing of the baseline of the FEV1. And the last one is to measure the variability in twice daily PEF over 2 weeks. The full name of the PEF is called peak expiratory flow rate. The positive results in adults is the average daily diurnal PEF variability more than 10% in 24 hours. And after 4 weeks of the anti-inflammatory treatment, that means the treatment by the glucocorticoid. Once we find the increase in FEV1 by more than 12% and more than 200 millimeters from the baseline in adults, we can conclude positive results of this variability in twice daily PEF over 2 weeks. How to do this examination? We need some special tools. Here is the tools to measure the PEF. It's called mini peak flow meter, and it's cheap. In China, you can buy it for less than 10 yuan. The asthma patient can keep this tool at home to monitor the PEF and the severity of their asthma. Here shows other spirometry findings in the patients with asthma. One is the documented expiratory airflow limitation. It presents the decreasing of the FEV1 with the decreasing of the FEV1 over FVC. In adults, is less than 75% to 80%, and in children is less than 90%. And others, including the increasing of the residual volume, which is caused by the emphysema, and increasing of the total lung capacity, and increasing of the ratio of the residual volume over total lung capacity percent. Those are the abnormal findings in the spirometry. Laboratory findings. For the asthma patients, we usually need other laboratory examinations. The first one is the allergen detection, for the detection of the suspected allergy. This picture shows the skin allergy test. In each drop of the liquid, there is a single suspected allergy. Once there is an allergy reaction, there will be a rash in the specific area. The second one is the arterial blood gas analysis. It's a very important examination for the asthma patient to evaluate the severity of the disease. If the patient with a mild condition, maybe we can find the results of this ABG is normal, or just with a slight decreasing of the partial pressure of the oxygen. And the level of the carbon dioxide is normal usually. And sometimes maybe we can find the decreased level of the carbon dioxide because of the compensatory increase of the respiration. In the other side, if the patient are in the severe condition, we can find both severe decreasing of the partial pressure of the oxygen and increased of the level of the carbon dioxide. That means the type 2 respiratory failure. And the third laboratory examination is about the bacteriological examination. We know that the acute onset phase of the asthma can be triggered by the infection of some special virus, bacteria, and fungus. So, if the patients are in the acute onset phase of the asthma, we need to analyze the infection of microorganisms. And next, we can dose them with appropriate anti-microorganisms drug. That's the laboratory examinations for the asthma patients.